Hi, everybody. My name is Naresh Bumma, and I'm assistant professor at The Ohio State University James Cancer Center in the plasma cell and amyloidosis program here. And we will briefly talk about bispecific T cell engagers in multiple myeloma and linvoseltamab. So in the last couple years, we went from having no approvals in this sphere to at least three approvals with more coming. There are currently three bispecifics approved for the treatment of relapsed refractory multiple myeloma. Two of them are against BCMA, so teclistamab and elranatamab, and one's against GPRC5D talquetamab. Linvoseltamab is a BCMA CD3 bispecific antibody that binds to CD3 on T cells and BCMA on myeloma cells, and then triggers a T cell mediated cytotoxicity of the BCMA expressing myeloma cells. So in the linker MM1 study, which was presented at ASH in 2022 and ASCO in 2023, we reported a response from these clinical trials. And we found that the tolerable dose that we're going to move forward with this drug was a 200 milligram dose, and overall response rate of 64%. With a CR rate of about 40%. What differentiates this antibody versus the other one, I think, is the big question, right? So very soon we may end up in a sphere here where we have 3 to 4 different antibodies for the same indication, which would be 4 more prior lines of therapy against the same target, which is B cell maturation agent or BCMA. And the question is, which one do you pick for? And the response rates based on the clinical trials are not very dissimilar. They're all in the 65 to 70 range with good CR rates and duration of responses that are fairly comparable. I think one of the things that does separate this one from the other antibodies is the risk of CRS or cytokine release syndrome. So cytokine release syndrome, it happens when the T cells become overactivated, leading to a release of inflammatory markers such as cytokines, and those can lead to a various degree of reaction leading to hypertension, fever, and sometimes very catastrophic side effects. So compared to other bispecific T cell antibodies, linvoseltamab has a lower risk of CRS at 37% versus some of the other ones, which is as high as 80%. And the majority of these were grade 1 or grade 2. And we believe that this may be because of the antibody structure itself, that it leads to less CRS activation. Also, neurotoxicity, as defined by ICANS, is lower in this with this molecule as well, at only 2%. We haven't seen much of a neurotoxicity with this specific antibody compared to rates of about 5 to 10% in other antibodies as well. Another big issue with these modalities across the board is the rate of infections, and that maybe has to do with that these patients were a heavily pretreated population and had a fair amount of lymphodepletion therapy prior to hand, and also that we're modulating T cells. So we're seeing higher infections and also some unusual infections such as CMV, PGP, and so on and so forth. So compared to other molecules, linvoseltamab has a lower risk of infection at 37%, which was fairly manageable. And we, as the study evolved, recommended a more aggressive prophylaxis with PGP prophylaxis, antiviral prophylaxis, and consideration for repletion of IVIG in patients who had hypergammaglobulinemia. Also, in terms of formulation, this is an IV formulation, not a subcutaneous one as some of the other ones, but the step-up dosing is done over 2 weeks on day 1 and day 8, which makes it a little bit more predictable. So the time in the hospital is less. And also, given our experience with this in the trials, the side effect profile is fairly predictable. So the CR, we can predict the time frame during which to expect cytokine release syndrome and or to expect neurotoxicity, and have appropriate measures in place to be able to counteract those if we were to need to. I believe this is what makes one of these drugs a little different one the other. Now there are trials that are coming up right now looking to explore this in combination with other myeloma therapies, and also to explore it in earlier lines for treatment of multiple myeloma. So I'll be very excited to see the responses from these trials moving forward. With that, I thank you very much for your time.